Hello, everybody. Welcome back to the Doc Talk podcast. I'm Dr. Shazma Mathani.
And I'm Dr. Sheila Wijaya-Singha. And today we're super excited because we're diving into episodes 12 and 13 of The Pitt, which is 2 hours that basically function as one long mass casualty story. We're still doing 2 episodes per podcast as we catch up everyone before season 2 drops in January 2026. And this week we're covering the hours of 6 p.m. and 7 p.m.
So this 2 hours really is this big MCI or mass casualty incident arc that kind of blends into the other. So the first episode, we kind of see at the end of last episode, we heard that this is happening, that there's an active shooter at Pitt Fest. And then this first episode starts with them preparing for it, getting ready. And then as the patients start coming in, that really rolls right into the next episode after that. And I mean, if you've worked in emergency medicine, this is just watching this unfold is some of the most real TV that I have ever seen.
That's wild. I'm actually super excited. I'm really interested in hearing your perspective on this, Chaz, because as a family doctor, I don't get to see these sorts of scenarios. We're always the backup to emerge, which is what happened in the episode as well. But I cannot wait to ask you about these questions because I know that this is something that you live with daily, and it's one of the most stressful situations that you can be in as an emerge doc.
Mm-hmm. Yeah, absolutely. I'm really excited to dive right into this episode.
So when episode 12 opens up, the team has already had a brutal day. We have seen so many difficult cases come through, like the drowning, the cardiac cases, the heart cases, the testicular torsion, the pregnancy loss. There's barely any time to even catch your breath. I felt that watching it. But when this mass casualty alert hits, Shaz, that was super overwhelming. Can you tell us what it feels like for you in real life when you hear that announcement?
Yeah. So, I mean, thankfully, in Canada, MCIs are quite rare. And I think that, in my opinion, that has a lot to do with our much stronger gun control laws that we have in Canada. However, there are other things where we would have MCIs. So back in the 80s, this was way before my time in medicine. There was in the late 80s, there was a massive tornado that came through Edmonton.
I remember that tornado.
Yeah, so there would have been an MCI that was at the hospital at both trauma centers because all the patients would have come in for that. A few summers ago, there was a festival just outside of Edmonton where a massive stage collapsed, and there would have been an MCI called for that, for example. So it's not always with active shooters, but this is definitely a common one in the US. And so I've never been involved in this significant of an MCI, but I will say just the thing that stood out to me or what I felt was when you have one of those just really shitty shifts when it's one thing after another and you're just running and running and running, one sick patient to the next and all you can think is what else could possibly happen? And then something even worse comes in. That's what this felt like, because as you mentioned, Sheila, this shift is full of badness. And then the worst possible thing that could be coming in is what happens. And so that's what it felt like for me, of just the pile on of that shift and then having this really, really awful thing. And when you hear that, or when you hear something like that, even if it's EMS calling in saying there's a pediatric trauma or a pediatric code, just extracting from my life and my world, that's going to be bad. So yeah. It's just, it's hard to near the end of a shift, you just kind of see the finish line, and then something like this happens. It's challenging to push through that for sure.
And that must be so hard because you're already running on a bit of empty after, emotionally, physically. So I can only imagine how difficult that is. And you work at a trauma center, Shaz, in Edmonton. And I found what was really interesting in episode 12 was the coordination between all the departments that came together so seamlessly. Prior to that, we had seen some conflict happening between departments, and it was sort of all melted away, where you see anesthesia came together with surgery, administration actually came together really well, the blood bank, security, the whole hospital felt like it snapped into place just for the goodness of being ready and prepared for what was coming.
Yeah, that was really beautiful to see that. And then kind of also seeing Robbie just take command. That is very accurate. It's usually the emergency doctor that's the incident commander in an MCI. And so he had this group huddle at the start, kind of let everybody know what was going on. The code MCI, or the MCI protocol was instituted. And so that meant that they were getting supplies from other hospitals. There was, blood that was being helicoptered over, all these things were immediately enacted. The surgeons came down, the ORs were cleared to make room for potentially the real need for ORs for all these injured patients. like, let's move the stable patients over to family medicine. Let's try to discharge people as much as possible, close the waiting room, like do ambulance diversion. Like all of these things are absolutely what would happen in real life because you want to try to just give as many resources as possible to the ER as these patients start rolling in.
So let's shift over a little bit to a teaching corner here, because I want to hear you. So you're saying MCI, which is the mass casualty incident. Can you take us through, Shaz, like what exactly happens in that moment? Because you did sort of allude to that in that moment, but the color system that they use, like take us through that.
Yeah, so MCI or mass casualty incident. So that is, I mean, essentially when you are expecting to have a lot of patients come in to the ER needing care. And so our MCI protocols and our MCI triaging system all comes from military experience, right? And so we actually see when Dr. Abbott
he was
comes
so good
back,
in this.
he was so good. And like, he was like right in there. And he alludes to the fact that he's had military experience in like the little side conversations that he's having. And you can see that it makes sense in terms of his ability just to step up really quickly. And so when we like the thing that's really important when you have an MCI is that you have limited resources, both like equipment resources, but also human resources compared to the number of patients that you have coming in. And so you have to have this really quick way of triaging patients. I don't know if you remember like Dr. Robbie at the front saying like, hey, 10 seconds per patient, right? Like you have 10 seconds to decide what color they are. And then that decides what part of the hospital they go to. And so the triage system, it's based on colors. So red is someone that has immediate life-threatening injuries and they're salvageable. So what that means is they're actively trying to die, I would say, but they're not dead. And any intervention, like some simple interventions could potentially save their lives. So that would be a red. Yellow is someone who is like serious but stable. So like a broken bone, for example. So they need treatment, but it's not something that's life-threatening that needs immediate intervention. Green is what we would call the walking wounded, right? So someone that has like a laceration that's kind of like is otherwise completely okay. Maybe has like some bruising, a fall, that sort of thing, a head injury, but they're awake and talking. Like these are all things that we would call the walking wounded. And then black is deceased or injuries that are incompatible with life. And so this one is kind of the most challenging piece from an MCI standpoint in that triage system, because in a normal circumstance, and we'll get into this when we talk about Jake's girlfriend, for example, right? So in normal circumstances, if it was just one patient that came into the ER that was presenting with what would be categorized as a black, you would pour all your resources into that patient to try to save them. But in the context of an MCI, where you have dozens and dozens of other patients that are requiring resources, it is a well-accepted thing that if somebody is deemed a black, it's a hard thing to do, but you stop because you know that pouring those resources in is going to have the least likely chance of a positive outcome. And then you're taking resources away from the reds, for example, which like were even a small amount of resources could be life-changing for them. So that one's often the most challenging one. And that's kind of that triage system that we go through when there's an MCI that comes in.
So that's like real triaging then, right? Like really prioritizing. But I can only imagine the challenge and like the moral difficulty that you have in making that decision. And you only have 10 seconds to say, this is what this is, this is what this is. Like Shaz, like, and then seeing that also the yellow patients can convert very quickly to red.
Yes.
And just
and we saw that throughout the episode.
Oh, yeah. So I felt I had to like pause a lot during these episodes rewatching them because it was very overwhelming to watch, and the speed at which they were going was so impressive. So like when that first wave hit where the police cruisers are coming in and bringing multiple people in at the same time, that pace was so fast.
Yeah, and like that is where I actually think the accuracy and the medical accuracy really shines. They had their package, they had the wristbands ready. There were the two doctors at triage that were like quickly triaging people, slapping those slap bracelets on and putting that chart on their wrist. And so, I mean, it's fast, it's messy, it's loud, it's chaotic, but you see all of these different teams, even like from the triage to when they roll into hospital, taking ownership of different pieces of the resuscitation. So whether it's the airway, whether it's procedures, it's all kind of happening simultaneously. And we've seen this throughout the season with the traumas, right? The individual traumas that have come in, but now you're having this happen stacked on top of one another, and everyone is just in there kind of working in unison. And like, of course, things are not going to go 100% perfectly, but I think that this was a very accurate way to portray this.
I want to just take a moment for Dr. Shen, who like casually with his like Slurpee in his hand kind of came in and was like,
Like, yeah,
oh, yeah, like
good.
I'm good. Like these are like, it really highlighted that there are very many different characters and how people navigate the emerge world. And that was just like a side note. But like, I agree. Like I had a hard time, like it was funny watching it again actually. And I encourage people to watch it again because you see different things that, because you didn't know like where to look sometimes because it was so quick. The tourniquets, the chest tubes, the blood being put in, like it was very all at once, which sounds very accurate.
Yeah, and the interesting thing is like these are the episodes where we learn the most about how the blood bank works and how like blood transfusions work, because so many of these injured patients are bleeding and require blood, and so the blood bank almost becomes like a character in this whole symphony of things happening. And so I think it's important to kind of, for our listeners, because there were parts where it was like men get O positive, women get O negative. And so that was, and that is how we work in real life as well. And so the reason for that is because positive blood has antibodies in it versus negative blood does not have antibodies in it. O is the universal donor, right? So any blood type can accept O blood. And so that's where like the hospitals are always stocked with as much O blood as possible, because when you don't have time to do a match to see what type of blood you need, the thing that you can give them safely is O blood. In women of childbearing age, you don't want to expose them unnecessarily to antibodies because that can affect future pregnancies. And that's exactly why women of childbearing age are like prioritized with O negative blood and men are prioritized with O positive blood. The other thing that kind of came in here was the rationing of the blood, right? You saw that happen almost instantaneously, where it was like, hey, 2 units max per patient because we're running out of blood. They were, waiting for blood to be sent in from a neighboring hospital. And so that also becomes challenging because you're starting to ration resources pretty quickly in these situations where you have a lot of patients to manage.
A little quick plug for the Canadian Blood Services here as well, right? Shaz, like this is where blood donation levels have gone down across Canada. And even though we don't get these mass casualty incidents in the same frequency as we see in the States, really important to still consider donating. And it's an opportunity for us to give back to the communities that we live in.
Yeah, and just a reminder, like you can donate blood, you can donate plasma, you can donate platelets.
Organs.
Like there's so many different, so many different blood products with Canadian Blood Services that you can donate. So please, like, check it out. Just see if you're someone who's eligible. Most people are, and it's just a really, really positive way to make a huge impact on so many different lives.
So much. So let's do a quick teaching corner here too, Shaz. I'd love to hear from you, sort of something called the ABCs. And can you take us through that as an emerge doc?
So even in the chaos of the emergency department, when we talk about traumas or cardiac cases, we always talk about sticking to the ABCs. And so A stands for airway, B stands for breathing, and C stands for circulation. And the reason that they're ordered in this way is because it's almost like a stepwise thing. Circulation, which it doesn't matter if you can't breathe, for example. Breathing doesn't matter if you don't have a way to get oxygen in from your airway. And so that's why it's a very stepwise approach to things. So airway is always first because nothing else matters if you don't have an airway. And so that means, can they get oxygen in? Do they need to be intubated? Breathing has to do more with the lungs and what's around the lungs, right? And so is their chest expanding properly? Do they have trauma? Do they need to have a chest tube put in? Do they have what's called a tension pneumothorax, or a part of their chest that is so injured that it's not allowing the chest to move properly? And then C is circulation. And so is there any major bleeding either outside the body or inside the body that's causing the blood pressure to be low? Do they need blood products? Does there need to be like a dressing or pressure that's put on something that's bleeding actively in order to prevent ongoing blood loss? And so this is this is the bread and butter part of trauma care in the emergency department, is making sure that you have the ABCs. And this is something that you can assess in seconds, like quick kind of what we call a primary survey, head to toe exam to check your ABCs and just identify injuries and intervention points as you go along and start intervening while you're continuing on with that primary survey.
And what really struck me was that there wasn't, like, you didn't need an x-ray, you didn't need a lab to do this assessment. This is really clinical judgment that you're using in that quick head-to-toe look, like you're saying. And we tend, especially with our learners, we always have to still emphasize the importance of clinical skills, like how to do a physical exam very quickly versus relying on these other things that take time. And in that kind of incident, you don't have that time.
And I think for, our medical learners out there, I mean, if there's a lot of focus placed on history, which is so, so important, like you can make really 90% of your diagnoses with history, except for this situation, right? So this is the one situation where the physical exam really shines in trauma, because that, like, often the patient is either unconscious or not able to talk or really can't give you a history. The only history you're going to get is from, EMS or whoever bringing the patient in. And so that's where the physical exam piece actually becomes really, really important.
So I felt like I held my breath for all of episode 12, and then I kept holding my breath for episode 13. Because when we see episode 13 start, you can just sort of start to see things start to crack because, as you mentioned up front, like the resource issues started to become very evident in terms of like the supplies were running out, people were getting tired. They were reusing things that we would never reuse in any other situation. So can you talk us through this? Because I feel like you probably were screaming at the screen at this part where you're like,
screaming at the TV. And it was a hard no. So you can see that there's this part where like Dana was wiping down the laryngoscope blade. So that's the equipment that we use to intubate people, to take a look and see their vocal cords and pass the tube. And I'm like, there is no way in real life that ever happen. Like IPC, like infection control, would just lose it if that happened. So I actually don't like that one. I mean, maybe it does happen in MCI. I can't imagine that would ever pass the sniff test. And like, so that one definitely like stood out to me. I really don't think that would ever happen in real life. The other kind of thing, the blood donation, right? So Dr. King, Mel wanted to donate her own blood for a patient, the mother of the deaf patient. And they set up a little blood donor clinic. And like, no, that also wouldn't happen in real life. There's like such rigorous screening that has to occur from a blood product and screening standpoint that Canadian Blood Services does an excellent job of. And so like that would be, I mean, medical legally, like all these things, like that would not happen in real life. I mean, it was a beautiful TV moment.
It was a beautiful TV moment. Yeah. She did say that she had just been cleared on a lot of the things that we do check. Yeah. But yes, I agree. I was like, oh,
that wouldn't hold up in court. That one would not hold up in court. I mean, like risk benefit, I know that like it's just, in medicine, everything is risk benefit. I just don't know that this one would fly.
Yeah. I mean, there's so many moments of like MacGyver in that stage where they were like doing intraosseous drills into the bones and bedside procedures that were sort of like, does this actually, I was just waiting to ask you, I'm like, do these happen? Because they've run out of everything at this point.
I have to say that like the skill that emerge, other than airways, I'll say the skill that emerge is the best at, especially like in this system of like just being constantly under-resourced, is MacGyvering things. Yeah. So like this is something that we are so good at, of like improvising in the moment of like, well, I don't have this, so I'm going to try this, or like I don't have the exact right equipment that I need, so I'm going to like fashion something that's going to work. And we do this a lot in Emerge. And I think that this is actually a really good moment where Javadi shines. And so I like love this part because she, like, there's like the interaction with her mom at the bedside, and she's putting in a chest tube, and like her mom's like hovering over her, like trying to like get in there and like, do some teaching. And she turns to her and like, pardon my French, she's like, read the fucking room, Mom. And I was like, yes, that is like, it was so good. I was like, finally she found her confidence and found her voice. I mean, and like,
and it was in front of Mateo, the nurse, which was
like, in front of Mateo. She like also was doing all the MacGyvering in terms of like using a Foley and like using a urine bag or whatever using an ET tube for a chest tube, and then hooking it up to a Foley bag instead of like the usual like vacuum bag that we would use. And like, it was just amazing to see her character shine, because she's always been like this like meek little, very young medical student. Last episode, we found out how young she actually is. Like, she started medical school or college when she was 13.
13, yeah.
So yeah, I mean, like you really get to see her character start to shine.
That's amazing. Mm-hmm. So tell us very quickly, like, what in these episodes, Jazz, would never happen in real life?
Okay, so there's a few things that stood out to me in these episodes. A couple we've already talked about, but like the bit of comic relief I really liked is like when Whitaker put the IO into the awake clown.
The IO is in the bone, like the bone. The IO is the bone.
Yeah, the intraosseous. Yeah, the intraosseous. Yeah, so it's like a way to have access for giving medications and giving blood through a bone instead of through a vein. And so, but it like hurts. It's like a drill where you like drill a piece of metal into someone, and like it is really good access, but like you wouldn't do that in an awake patient. So when Whitaker did that,
another moment for him,
I couldn't help but laugh. Plus, also the clown and the makeup, like it was a really good like moment of levity in this episode. But no, you would never put an IO in an awake person. We talked about this already, like donating your own blood without any screening. No. The moment where Santos did the Reboa, like, which is like a procedure effectively to like stop kind of below the aorta bleeding, like that is a very invasive, very specialized procedure that requires like significant training to do, that would absolutely not happen in
I
real
mean,
life.
Santos is very confident.
She's pretty cowboyish, but like that would be like, I mean, no, that would, even a lot of emerge attendings don't know how to do that procedure because it's like a very specialized trauma surgery procedure. The burr hole, like when Mohan did the burr hole with the IO needle, also no. Like, I don't know, there's something about the burr holes being done on TB is like a heroic measure. That doesn't happen.
I mean, it looks very good, right?
It looks
like, it's
so
pretty
badass,
dramatic.
but it's like, it's not a thing that happens in real life. And then the last one that kind of stood out to me is that tactile intubation that Robbie does, where he like tried to kind of like feel with his fingers to direct the ET tube. Like that's pretty much something that doesn't happen ever.
Interesting.
Yeah.
Well, you also have respiratory therapists, which they're changing up for next season, right?
Yes,
which will help with the intubation. So they took the feedback, which I love about the show, is that they are taking feedback in real time. So season 2, we're going to see different healthcare providers that aren't presented in the same way. But, you know, all of that, I love that you're like debunking some of these things, but I also really like these moments. Like they were fun to watch. Like as somebody who's just watching for entertainment, I'm like, these are, and they're highly emotional. Like, so I get it. Like they're not going to happen in real life, but I'm like, okay, this is where we get a little bit of the fun part of watching this too.
These are high entertainment value procedures and things for sure. For sure.
Yeah. Yeah. So this next part was hard. You know, this is like the emotional center of the episode where this is when Jake's girlfriend, Robbie's stepson, his girlfriend, Leah, she comes in with a chest wound. And it's the first time that we actually like take a moment and things slow down in these 2 hours. And it's so hard.
And like, it's interesting because when they pull up in the back of like, I think it was like a pickup truck or something that they pulled into the back of.
Yeah.
And you can see Robbie's face go from like relief of seeing Jake.
Yeah.
And then his face sink when he sees Leah.
Yeah.
And he immediately, like you immediately recognize as an emergency doctor, you would immediately be able to like look at that individual, look at that patient and know those are like significantly life-threatening injuries that are probably unsurvivable. And I think that you could see that written across his face in like such a quick moment when they were outside. And it's just, I mean, we see that they have like Jake and him have such a special relationship, and then, you know, that relief and then that angst and tension. It was you know, it was a very very like heightened emotion type moment for sure.
Yeah. And you mentioned earlier that they did ration. They said 2 units per patient of blood, and at this point he gives her 4 when there's rationing happening, and that was a deviation from their protocols. So, and I think everybody understood it. Like that was, but it was also sort of deviation.
I know. And like, just even the way that they shot that scene, I found really fascinating, right? You can see like the close-up of Robbie just like working on Leah. You can feel that emotion, right? Because he just really wants to save her life. There's a personal connection there. You can see like Abbott in the background that kind of keeps looking over. You see Dana that kind of like has this like look of like turmoil and on her face, and kind of keeps like her and Abbott are having these looks back and forth, and a few like kind of passive comments that are made initially because he's absolutely deviating from protocol. And it's hard because I mean, like think about whether like if you were in that situation.
Oh, 100%.
I mean, imagine having an MCI and somebody that you know walks in the door and you know that you're only allowed to give them 2 units. I would absolutely struggle with that as well.
Yeah. Yeah. It was really powerful also when Abbott stepped in. It was like he needed to take that moment, and he had to be the one that made that decision to step in and stop Robbie. And he was quiet and gentle, but it was like his moment of leadership in that moment to kind of step in, because Robbie was lost in that case, understandably.
Yeah, and you can exactly, and like everyone I think could empathize with that. And I like you said, I really like the moment or the way that Abbott just like stood beside him. He wasn't yelling. He just like quietly said those words to Robbie. And it wasn't right away that he stopped, but like I think that it's clear that those words really stuck. And then, you know, they gave like the one more unit or something that was given, and then they stopped, because I think of it like he finally was able to come to terms with the fact that like this was an unsurvivable injury. And then like that is, I mean, from there, right? It's just like everything you can see Robbie just like fracture and break in that moment.
So I think what episode 13 does so well is showing like the after. There's staffer wandering around. There's a lot of quiet moments now after all the busyness and the rush of what just happened. And like the students are frozen. And we see the unraveling of some of the most steady characters who have been able to hold it together. Like King was donating her blood. She was like on the whole time. And then we see her start to unravel. Like that was so moving.
It really was moving. And then even just like the interaction that her and Robbie had there, right? Of like, never apologize for caring for your patients, because you shouldn't, right? Like there is like, we are humans. And I think that there is this facade or this expectation that Emerge people are just like these robots, right? That they go from like one patient to the next and there isn't any sort of emotion in it. And like when you're in it and like you're going through the algorithms and you need to be there and like be on and do the things, like sure, there are some like robotic aspects of it because sometimes that's the only way for you to like survive in that moment of how terrible the case is. Like you dissociate yourself almost from it and then just like make sure that you're providing good patient care by going through all the steps that you know and that have been ingrained in you for years and years and years of like residency and medical school. But then after the aftermath, right, is where things just collapse. And that like post-recess quiet is very real. Like there's, the empty trauma room of like all the stuff on the ground. There's like just this quiet that comes over the Emerge. And a good example of that earlier in the season was that drowning. Exactly. And they actually even show the service worker like mopping up the floor. That is like, I mean, that quiet, it was hard to watch that because I could feel the emotion that like all of these healthcare workers were feeling in those moments. It's very, very real.
So the final scene that we see is one of the most like beautiful but so real moments of like the moral injury that we see in healthcare workers that I've ever seen on television.
This one, yeah, I mean, like I was like bawling for like at this one. That moment with him and Jake, right? He comes and he like again breaks protocol, brings Jake into the makeshift morgue and shows him Leah. And then they have this interaction of like, well, why did you save her? Why couldn't you save her? And then that is just what like breaks Robbie. He goes through every single patient he's lost that day, one by one, in like such a human moment. And like, I think it really drives home like that those patients, like they live with us forever. Like those patients that we've lost, they live with us forever. And like and you kind of go through everything over and over in your brain of like, well, what could I have done differently? Like, could I have done something differently in this situation to save this patient? And you can see that happening with him in real time. Like you can see like he's holding his head and he's like, you can just see him like trying to go through it. Like I tried. There was like nothing else I could do. I tried to do everything. And I mean, there are different breaking points along the way of being in a Emerge. Sometimes it happens on shift, rarely, because we really try to compartmentalize and like keep it together. Sometimes it happens when you get home, or sometimes it happens months or years later when you're talking to your psychologist, right? Like it's not this this like prescribed way that this happens. It sometimes just like bubbles up to the surface and you just can't keep it in anymore. And I think that's what we saw here with this.
Yeah. Okay, so let's lighten it up just a little bit before we get into our awards. So what is the tally now for Whitaker with his scrubs?
I think we're at 5.
Yeah.
I think we're at 5 scrub changes for him now. What about, what do you think the best quote was, Sheila? Anything that stands out to you?
Yeah, I mean, I think Abbott was a bit of a rock star. Like he was in his element here and he said basically like, this is no frills combat zone medicine. And he wasn't fazed by a lot of this because this is what he's seen. I thought that was very, very much on brand for him.
There were a few points that actually like stood out for me as like just being really realistic as well. So like those, we talked about those slap bracelets, the Sharpies with the little wrist charts, because you're not going to have identification on all these patients. Was like, it was really good to see that realism from like the MCI standpoint in this episode too.
And I know it wasn't maybe real, but one of my favorite moments was still when King was donating her blood, because even though it wasn't legit, it was like the intention and the heart that she presents all the time is like quite beautiful.
Beautiful. And that last little, the thing, I mean, so I am an Emerge doc. I've been listening to EM rap for like since I was an R1 resident, even in like as a 4th year medical student when I knew I was interested in Emerge. And we know that there is a lot of crossover between people who work with EM rap and also are consulting on this show. And so that shout out that Langdon gave of like when Mohan was like, hey, how did you know how to do that? And he's like, oh, it was from an episode of EM rap. And I was like, oh, that's perfect. Like chef's kiss, like way to wrap it up and bring it full circle. It was so great. Okay, so let's wrap it up. I mean, we have a lot of medical learners listening to the show, so let's do some take-home points for our medical learners today. So I want to get it started. In an MCI, it's really important to know that speed matters. So doing triage really quickly, it matters a lot more than perfection. You're not going to get everything right, and you're going to be under-resourced. So that 10-second triage can save more than lives. It can save more lives than just a detailed assessment. So you have to be quick, and you have to get through that as quickly as possible.
The next thing that we want our medical learners to know is that like your emotional reactions are normal, and debriefing is a clinical skill. And it's so important. This protects your space. It protects your emotional self when you go home at the end of a day. And that is certainly with emerge shifts, but any shift that you may do in whatever part of medicine that you're doing, there's going to be loss in this work. And it's really important to acknowledge that and get the help that you need if you are in need of processing and managing sort of some of those emotional reactions. And those are very normal. And please do seek out help if you are struggling.
And lastly, protocols exist for a reason, especially when it comes to massive casualties and kind of blood protocols. Breaking them really does have real consequences, even when it's emotionally charged. We saw that throughout this episode. But just remember, it's okay to ask questions, and you should ask questions, but remember that protocols often exist for a very good reason.
So these 2 episodes were a lot. If you're still catching your breath, trust, we're right there with you.
And this is exactly why we wanted to recap the Pitt in the first place, because the way medicine gets portrayed with this much emotion and truth, it really opens the door for us having these real conversations about what emerge is really like, what kind of life in a hospital and acute care really feels like, the teamwork, the chaos, the moral distress and weight of these cases. This show just brings it to life so accurately.
So we'll be back in 2 weeks with episodes 14 and 15, which we pick up right where this mass casualty arc leaves off. There's a lot to unpack in the aftermath, both medically and emotionally, so make sure you're caught up before our next podcast drops.
And if you're watching along with us, send us your questions. We love hearing what stood out to you, especially the scenes that surprised you, made you wonder. If you have any questions about whether this actually happens in real life, send us a DM on Instagram. We'd love to hear from you.
Thanks for listening. We'll see you in a couple of weeks for our next recap.
A reminder that the Doc Talk is for general information purposes only. This podcast is not intended to replace medical advice from your doctor. While we are doctors, we are not your doctor. Always speak to your own healthcare provider for questions related to your personal health needs. And be sure to follow us on social media at the Doc Talk Pod. And of course, please like and subscribe for our podcast too. That really helps us kind of move up the algorithm and get to more listeners as well.